Hey guys, my name is Grace, and today I'm going to be doing a journal club presentation on the effects of dexmedetomidine in preventing postpartum depression for women with prenatal depression. So this is kind of an outline of everything I'll be going over today. We have our study background, methods, results, and then I'll be doing a discussion on key takeaways from the study. Going straight into study background, in this portion I'm going to be talking about current guidelines regarding treatment of postpartum depression, and then I'm going to do an overview on dexmedetomidine's drug profile, and then finally I'll be going through some previous trials that have led up to this one. So before we go into the study, I'm going to be going over some definitions we'll be seeing throughout the presentation. First, we have perinatal depression, which is kind of an umbrella term for both prenatal and postpartum depression, and it includes any type of depression occurring during pregnancy up to 1 year after childbirth as well. So then prenatal, also known as antepartum depression, is any type of depression that occurs during pregnancy. And then postpartum depression is depression occurring up to 1 year after childbirth. And that's what we're going to be focusing on today. So now going into postpartum depression. This is actually the most common psychological disorder among women postpartum, with an incidence of around 10 to 20%. It's characterized by profound depressive symptoms that persist for over 14 days and occurs within 1 year after childbirth. Onset of PPD is typically around 4 to 6 weeks after childbirth, but as I mentioned before, symptoms can also appear later on up to 1 year after. This shouldn't be mixed up with something called baby blues. Baby blues is also a type of condition that's experienced by around 85% of new mothers after giving birth. And it's also characterized by depressive symptoms just like PPD, but the effects only last for 1 to 2 weeks, and usually symptoms resolve on their own without need for medical treatment. Now, expanding into the consequences of postpartum depression, this is pretty significant because consequences go beyond just the mother, as PPD affects both the mother, the child, as well as the spouse and other family members involved. And going further into the effects of PPD on the child, the first 3 months of a child's development are honestly the most critical in establishing the mother-infant bond and laying the groundwork for the child's emotional, social, and cognitive development. So disruptions to this due to a mom kind of maybe being too depressed to really bond with her child, take care of her child, or form that loving relationship with their infant can lead to long-lasting negative effects on the child's development. Alright, so quick knowledge check before we move on to the next section. I want you guys to try to rank the following countries from longest to shortest length of paid maternity leave. I don't expect you guys to know this, so you can take a guess if you'd like. So these are the rankings of length of maternity leave around the world, and if we see the US is last on the list with no paid leave. In fact, almost all countries around the world offer some type of paid maternity leave, but the US is one of the only countries that doesn't measure up to these global standards. We do get 12 weeks of unpaid leave under the Family Medical Leave Act, but that's about all we get. I bring up this knowledge check just to stress the fact that not only are mothers expected to pick up their life back at home after giving birth, but they also have a whole new life to take care of, and on top of that, they're expected to go right back to work shortly after childbirth, and that leaves little to no time for them to recuperate and recover their physical and mental health. So PPD is something that we do need to stress and study more, and also expand interventions for as well. In the study that we're going to be looking at today, the screening tool that they use is the Edinburgh Postnatal Depression Scale, or the EPDS, and this is a self-rated scale, and in our study, positive for postpartum depression was defined as an EPDS score of over 9, and you can see on the bottom I listed out the scoring system. I won't be reading through it, but it's there for reference. So these are the current APA guidelines regarding treatment of postpartum depression. For mothers that have mild symptoms, psychotherapy is considered first-line first line. And then for mothers with moderate to severe PPD, typically antidepressants are preferred, specifically SSRIs, SNRIs, bupropion, and tricyclic antidepressants are some of the classes that we see the most often. But in terms of FDA-approved agents, we only have two that are specifically indicated for treatment of PPD. We have brexanolone, which is given as a 60-hour IV infusion, and then we have zuranolone, which is given orally for 14 days. And both of these are neuroactive steroids that work at the GABA-A receptor. They modulate that receptor to enhance inhibitory neurotransmission. Overall, one benefit of these FDA-approved agents is that their onset for symptom relief is a lot quicker as compared to our typical antidepressants, which take a couple weeks for them to really work. So the agent that we're looking at in this study is dexmedetomidine, which is a highly selective alpha-2 agonist mainly used in the perioperative period for its sedative, analgesic, and anxiolytic properties. Its mechanism of action mainly revolves around its inhibition of central sympathetic outflow by binding to alpha-2 receptors in the brainstem and inhibiting norepinephrine release. And this mechanism of action is thought to be helpful in postpartum depression because it reduces stress-induced depression caused by too much norepinephrine. Another potential benefit of this agent is that it may increase BDNF and decrease pro-BDNF levels, which are both involved in mood regulation and neuroplasticity. Some indications for dexmedetomidine include, as I mentioned before, procedural sedation. It can also be used as an adjunct in mechanically ventilated patients in the ICU. And one of the benefits of dexmedetomidine is that it has a very short half-life, so it can be quick, fast off, and help, which is good for managing the level of sedation without being too worried about respiratory depression. Some other indications include off-label as an adjunct for general anesthesia, and then one of the psych indications actually is that it can be used as an alternative agent for mild to moderate aggression seen with bipolar disorder as well as schizophrenia. A quick review on the adverse effects. The adverse effect profile of dexmedetomidine is actually pretty favorable for its class. But as expected, we do see an increased incidence of hypotension, bradycardia, as well as some other side effects such as xerostomia, constipation, and nausea. And then in terms of drug-drug interactions, it does have a potential for additive CNS depression or sedation when taken with other CNS depressants. Now, these are some of the dosing regimens for dexmedetomidine based on its indication. I won't be reading through each one, but I do have these here for reference. One thing I do want to mention is that if you see in the first box, the trial dose for the continuous infusion maintenance dosing is a lot lower than the clinically used dose for procedural sedation, which we can see is around 0.2 to 1 mics per kg per hour. So before I go into some of our previous trials, another quick knowledge check. Which of the following has the same mechanism of action as dexmedetomidine? And as a reminder, the MOA for dexmedetomidine is that it's an alpha-2 agonist. So the answer is clonidine, and some other alpha-2 agonists include tizanidine. And in general, I just bring this up because while there are other alpha-2 agonists on the market, so far none of these have been indicated as an antidepressant. Clonidine is used in some psych conditions such as ADHD and some types of anxiety, but it would be interesting to see any other alpha-2 agonists being studied in preventing or treating depression. So going into some previous trials, these two trials here are both preclinical animal studies done in mice, where they looked at the effects of dexmedetomidine beyond just procedural sedation. In the study on the left, they looked at dexmedetomidine's effects in reducing cognitive deficits associated with anesthesia agents, and they found that it was effective in reducing this through the increased release of brain-derived neurotrophic factor, or BDNF. BDNF is significantly involved with neuronal growth, neuroplasticity, as well as mood regulation, and so this outcome kind of opened the door for studying dexmedetomidine and other cognitive conditions such as Alzheimer's disease, as well as depression. Now, the study on the right also was done in mice, and they looked at the effects of dexmedetomidine in potentially reducing sleep-induced depressive behaviors in mice. And they found that dexmedetomidine did alleviate these behaviors, and it did this through modulating certain neurotransmitter systems, as you can see on the slide. Now, finally, we have the 2019 study, which is actually a human clinical trial done in China with a study population of around 600 women undergoing a C-section. In this study, they looked at dexmedetomidines' effects in reducing PPD symptoms among Chinese women undergoing C-section, and they found that it was very effective in reducing this, so their outcomes were met. And not only that, it was found that dexmedetomidine helped to reduce any self-harm ideations, as well as showing improvements in sleep quality. But one thing to keep in mind is that over 70% of patients at baseline did not have any antenatal depressive symptoms. So this study population mainly looks at women that are at lower risk and that don't currently have prenatal depression. Now moving on to our study is set up basically the same way as the last study I was just talking about, except we're looking at women that already have prenatal depression, whereas in the previous study, most of the women studied did not have any symptoms at baseline. Now, this study was funded by the Natural Science Foundation of Hunan Province, as it was also completely done in China. The objective of the study was to evaluate the efficacy and safety of dexmedetomidine in preventing postpartum depression for women that were undergoing cesarean delivery. The rationale of the study was that while we do have treatments for postpartum depression available, such as zuranolone, SSRIs, and other antidepressants, we don't really have any pharmacologic strategies for the prevention of postpartum depression. Also, there's only a few clinical studies so far that look at both the clinical use of dexmedetomidine for PPD while also looking at changes in BDNF levels. So this study looked at both of those. So we just went through study background, including previous trials that led up to this one, and now I'll be going through some of our methods as well as study inclusion-exclusion criteria and outcome measures that they were looking at. Now, this trial was our gold standard randomized double-blind placebo-controlled trial, and it was held across 2 different hospitals in China. Inclusion criteria included women over 18 years old that already had prenatal depression defined as a EPDS score of over 9. They also needed to be scheduled to undergo a C-section already, and they also needed to be ASA Physical Status Classification Grade 2, which basically is a system used to assess a patient's physical condition and predict their risks following or before a surgery. And pregnant women are listed under category Grade 2. In terms of exclusion criteria, I have them listed. I won't read through them all, but one of the main ones are some cardiac conditions such as bradycardia, hypotension, as well as any other cardiac condition conduction abnormalities. Also, a history of psychotropic substance abuse, as well as an inability to provide informed consent were exclusion criteria as well. Now, the treatment regimen was broken down into our dexmedetomidine group and then a placebo group. However, both were blinded with sufentanil. So first, right after delivery, participants were randomized to a 1-to-1 group to get either dexmedetomidine, 0.5 mg per kg and 20 mL of NS given over 10 minutes, or just NS given over 10 minutes, which is the placebo group. Immediately after this 10-minute loading dose infusion, all patients were given patient-controlled intravenous analgesia with sufentanil at a rate of 2 mL per hour for 48 hours. So in this group, participants were either given sufentanil added on to their dexmedetomidine, or they were just given sufentanil added on to their NS infusion, but both groups received sufentanil. Now, going into outcome measures, the primary endpoint was the incidence of postpartum depression screening at 7 and 42 days postpartum. And again, A positive incidence of PPD was considered an EPDS score of over 9. Some other secondary endpoints they looked at were incidence of suicidal ideation at 7 and 42 days. They looked at changes in plasma BDNF and pro-BDNF levels. They also looked at EPDS scores, insomnia scores, as well as some pain scores at 7 and 42 days postpartum. As for safety endpoints, they looked at the incidence of adverse events, vital changes, as well as Ramsay sedation scale scores to see if patients were appropriately sedated. And then they also looked at specific cardiac adverse events such as bradycardia, hypotension, dizziness, and more, which are commonly seen with dexmedetomidine. Now, as for statistical analysis, using a power of 0.9 and a two-sided test with a p-value of 0.05, they were able to calculate a sample size of around 270. However, estimating a dropout rate of around 20%, they readjusted that number to 338 with 169 participants in each treatment arm. They also used an intention to treat analysis for this study, so that kind of preserves randomization and helps minimize bias. Now that we went through the study design, I'll be going through our results, including enrollment, baseline characteristics, as well as our outcomes. So from March of 2022 to April 2023, a total of 355 patients were screened and assessed for eligibility across 2 hospitals in Hunan, China. Out of those screened, 338 women were actually randomized to the treatment groups, 169 patients in each group. If you look at the red box, you'll see that only 60 participants from each group were actually randomized and selected for venous blood sampling in comparing the BDNF levels. So not everybody had the BDNF levels analyzed before and after treatment. So these are the baseline characteristics of patients in this study. There weren't any significant differences, but to point some things out, mean age was around 31 years old. This isn't included in the chart, but the median EPDS score at baseline was 12, which is considered a possible risk for PPD. Some other things to note is that at baseline, most patients' mood was moderate, and also most patients did not have incidences of domestic violence or stressful life events at baseline. In terms of the pregnancy, for most patients, this was a planned and full-term pregnancy. And then in terms of some socioeconomic factors to consider, most patients had a higher education level with at least a college degree or above. Most patients were employed, and a very small subset of patients were in the low-income bracket. So as we know, when it comes to mental health disorders as well as other health disorders, social determinants are very important when we're predicting outcomes. So I would say that this group isn't necessarily completely representative of the real world. For the primary outcome, we saw that the dexmedetomidine group showed a 61% reduction in the incidence of postpartum depression at both 7 and 42 days as compared to the placebo group. And both of these results are statistically significant, if you can see in the red box, with p-values of less than 0.001. As for the secondary outcomes, we can see that for suicidal ideation, dexmedetomidine was also able to effectively reduce this by around 78% shortly after delivery, but these effects were only seen at 7 days postpartum and not 42 days postpartum, which shows that these effects may not be as long-lasting as we would like. In terms of our plasma BDNF and pro-BDNF levels, if we remember, BDNF plays a very crucial role in neuronal growth, neuroplasticity, as well as mood regulation. On the other hand, pro-BDNF, which is a precursor of BDNF, actually has some opposite functions, and it promotes feelings of depression and anxiety. So theoretically, in postpartum depression, we would want increased levels of BDNF and decreased levels of pro-BDNF. We actually do see this in terms of the treatment results. If you look at the chart, we can see that in the dexmedetomidine group, we not only saw an increase in pro-BDNF levels, but we also saw not only did we see an increase in BDNF levels, but we saw a decrease in pro-BDNF levels. And the way that they measured this was through serum levels of BDNF. And they did mention in the study that this was representative of our brain concentrations because brain BDNF can cross the blood-brain barrier very easily into circulation. So our plasma levels would correlate with the brain levels as well. As compared to the placebo group, the dexmedetomidine group also saw decreases in median EPDS scores at both 7 and 42 days postpartum, which align with our primary outcome results. In terms of sleep quality, we do see an improvement in sleep quality at 1 to 2 days, but this is only short term as we don't see these effects at 7 and 42 days, similar to the suicidal ideation. Finally, for pain scores, we saw that pain scores were improved at rest but not during movement. And one of the reasons why this might be is because if we remember from the treatment doses as earlier seen, the dose that they used in this trial is a lot lower than a clinically used dose for procedural sedation or analgesia. Finally, for our safety outcomes, we can see that there were no significant differences in adverse effects, except for an increased incidence of hypotension seen in the dexmedetomidine group. But if we look right under the red box I have highlighted, we don't see any clinically significant differences in hypotension requiring treatment. So this isn't a life-threatening side effect that we really need to worry about. One thing that we might want to do is just increase monitoring when it comes to vitals, just in case. Now, the author's conclusion is that dexmedetomidine was able to significantly reduce incidence of PPD in mothers that already have prenatal depression. And on top of that, it was able to maintain a favorable side effect profile and have some extra benefits such as reduction in sleep scores as well as pain scores and suicidal ideation. Now that we went through the study outcomes, I'm going to be going through a discussion on my take of the study as well as some strengths and limitations. Now, going into some strengths and limitations, one of the strengths is that they were able to appropriately blind both treatment groups using sufentanil. Since dexmedetomidine is a sedative analgesic, if they didn't blind using another agent, it would be pretty obvious which group is the placebo versus treatment group, so I thought that was pretty good. Another thing is that this is a gold standard RCT, double-blinded placebo-controlled trial, so that definitely helps to minimize bias. And they also used an intention to treat analysis, which helps to provide real-world applicability, as this type of analysis preserves randomization and includes all patients that were at the start of the study, regardless of their adherence throughout. The study also had a very high retention rate with 98.2% of the participants completing the trial, and they were also able to meet both primary and secondary outcomes to some extent. Some limitations include, I would say the largest one is that the cohort is limited to China, which limits generalizability of the study outcomes, and this kind of also coincides with the previous trials that we saw, which were also mainly based in China. The study also had a short follow-up period, so in terms of long-term effects, we might need further studies to look at that. And then another thing is that not all patients that were randomized were included in the serum level studies for BDNF and pro-BDNF levels. If we remember, only 60 participants from each treatment group were analyzed for that. And then finally, the EPDS scoring system they used to determine incidence of PPD is a self-reported system, so that does introduce potential for bias. But as we know in psych, most of these scoring systems are self-reported, and the EPDS scoring system is a validated system for PPD, so I don't think this is a huge issue. Now, my question for you is, after everything that we've gone over so far, as well as the study outcomes, is dexmedetomidine an agent that you would recommend in preventing postpartum depression? So for my take on the study, I do think that dexmedetomidine is a pretty promising preventative agent for postpartum depression in mothers undergoing C-section. And that's because when we look at current therapeutic approaches for PPD, most of them are primarily revolved around treatment, and we don't really have preventative strategies in place to begin with. But on top of that, even when it comes to treatment, Things like antidepressants take around 4 to 6 weeks to really provide symptom relief. And then when it comes to our FDA approved agents such as brexanolone and zuranolone, while those agents do work faster, it still requires a mother to make that separate appointment for her mental health to get these agents prescribed. And of course, I advocate for that, but realistically, right after a mom gives birth, especially if she's already dealing with prenatal depressive symptoms, it might be hard for her to consider like taking care of her mental health first when she has a whole child to take care of. So the fact that dexmedetomidine can be given on the same day when they're already scheduled to undergo a C-section and have delivery in the hospital, I think it's a convenient option for mothers that might not want to make that separate appointment to leave the house and go follow up. Of course, I think after initiation of dexmedetomidine, if mothers were to get this during C-section, it's still important that they follow up maybe later on when they're a little bit more settled down in life to follow up with their mental health continuously. Another thing to note is that some people might be concerned about dexmedetomidine's effects on the baby, and it is found that dexmedetomidine can cross the placenta as well as the breast milk, but so far no studies show that it's been shown to have any harm or like teratogenicity, so it is relatively safe to use in the pregnant population. I will say though, because this study had a shorter follow-up period, I would like to see further studies being done that assess longer-term effects and risks of dexmedetomidine to further kind of solidify that safety and efficacy profile. And I would also like to see more trials happening in places like the US or the UK, since most of these trials were, or all of these trials were based solely in China. But yeah, overall, thank you guys for listening, and hopefully this was an enjoyable journal club presentation for you guys.